I'm Alison Christy, and I'm going to be talking today about acute flaccid myelitis. I'm a pediatric neurologist here at Providence, and this is part of the Brain Thoughts Education Series. I'm going to start by going back a little bit in history, because this is a fairly new phenomenon, but epidemics are not a new phenomenon. And I'm going to talk a little bit about something called Encephalitis Lethargica. So this was an epidemic that occurred between 1917 and the late 1920s, around the same time as the 1918 flu, or the Spanish flu. It was described by Constantine von Como as prolonged somnolence with cranial nerve palsy. So people were basically comatose, and by cranial nerve palsies it meant their eyes weren't working, they couldn't swallow, they had trouble holding up their heads. And after they got better, they had Parkinsonism, meaning that, like people with Parkinson's, they moved slowly, they couldn't make big movements, they had trouble initiating movements. Children looked different. Initially, they looked the same as the adults. They also had headache, lethargy, they were comatose, they had these cranial nerve palsies. But when they got better, they had these very odd behaviors. They had personality changes, they had tantrums essentially with agitations and screaming and insomnia. They were very impulsive, they had precocious sexuality, self-mutilation, and they were very cruel, and they actually stole things. So things looked very different in children than they did in adults. And when we talk about epidemics, epidemics are a widespread occurrence of infectious diseases in a community at a particular time, like the way that the 1918 flu affected a community over a specific time, and the way Encephalitis Lethargica did as well. Epidemics come and go, and there are always new epidemics, and epidemics leave as well. Infectious diseases can look very different in children, and that's one of the things that we're going to be talking about today with this specific epidemic of acute flaccid myelitis. And we can't always distinguish between something that is infectious, like the 1918 flu, which was caused by the influenza virus, and something that might be a response to the infection, like Encephalitis lethargica. We don't know that that was caused by the flu, but it happened around the same time, so we think that probably the flu had something to do with why people got it. But whether it was the flu causing those symptoms, or the body's response to the flu giving a secondary symptoms from it, we don't know. So I'm going to talk about a 15-year-old boy who came into the emergency room with a facial droop and upper extremity weakness. 3 days before he came in, he had vomiting and he had a cough. His grandmother noticed a right-sided facial droop. And when we talk about facial droops in neurology, we care about whether it is involving both the forehead and the lower face, or just the lower face. Because the way we localize in neurology, the cranial nerve, the seventh cranial nerve, affects both the upper and the lower face. But if you have a stroke that affects the cortex, it will affect only the lower half of the face, because the upper part of the face is on both sides of the brain. Our patient had a full right-sided facial droop, and he went to urgent care, where he was treated for Bell's palsy with prednisone. The next day, he complained that both of his arms were weak. He was no longer vomiting, but he couldn't swallow any water, and he kept trying to, and it would run out of his mouth. He complained of double vision. He had a very profound facial droop, was drooling. His neck was very weak. He couldn't hold his head up, and he couldn't lift his arms at all. He was, at the same time, completely intellectually intact and was walking around like a normal person. On exam, he was intubated, but he could still follow commands, nod yes or no. He had a right-sided facial droop. His neck was very, very weak. He had no movement of his deltoids at all. His triceps, you could see him trying to move, but he couldn't get it anti-gravity. He could move his wrist extensors and flexors a little bit, but you could push it down. And he had normal strength in his fingers and hands. He had normal strength in his legs. He had sensation intact everywhere. And he had no reflexes in his upper extremities, but brisk normal reflexes in his lower extremities. And his toes were down going bilaterally. He had a lumbar puncture that had no red blood cells, but 392 white blood cells with a lymphocytic predominance. The glucose was normal, and the protein was elevated at 82 milligrams per deciliter. So this is a cerebrospinal fluid that looks infectious or inflammatory. There are white blood cells there, and the protein in the cerebrospinal fluid shows us that probably the body is mounting an immune response, and there are antibodies there in the cerebrospinal fluid. And when he got imaging, you can see a white line right through the center part of the spine on both pictures, right through the center. And when we look at the axial view, you can see this perfect H in the middle of the spinal cord, showing the gray matter of the spinal cord perfectly right there in the middle. It's hyper intense all throughout his spine. As neurologists, we ask, where might this lesion be? When someone comes in and says, my hand is weak, we try to think about what kind of problem in the brain could cause hand weakness. And we think about not only the brain, but the spinal cord and the nerves. And we go through a whole list of different places that can be involved when we're trying to figure out what might be wrong. When we are thinking about, so we go through the cortex, the white matter or the myelin, the basal ganglia or the cerebellum, which don't control whether you can move, but how you move, the brainstem, spinal cord, and then we make a division right about here, and we go down to the anterior horn cells, the roots, peripheral nerves, neuromuscular junction, and muscle. We make a distinction there because the things that are above the anterior horn cells are controlled by an upper motor neuron from the cortex. The things below there's a lower motor neuron that's in the anterior horn cells, so the things that are below the anterior horn cells are controlled by the lower motor neuron. And this makes changes in the presentation. So when you have an upper motor neuron lesion, you have brisk reflexes, you have spasticity or high tone that's rate related, you have very high tone just at baseline, and you have upgoing toes when you do a Babinski reflex. The lower motor neuron lesions cause poor reflexes, a flaccidity, meaning very low tone, hypotonia, and downgoing toes. So here we have a 15-year-old boy who has progressive bilateral proximal upper extremity weakness. So his arms are weak, starting here, but then his hands are strong. And he has brainstem symptoms like the double vision, the drooling, difficulty holding up his head. It happened over 3 days following a GI illness. He has the increased white blood cell count in his cerebral spinal fluid and increased protein, suggesting something inflammatory. And he has these gray matter lesions on MRI. And all of this points to some kind of infectious or post-infectious process that's going on in the anterior horn cells of the spinal cord. So he was diagnosed with acute flaccid myelitis, sometimes also called acute flaccid paralysis, and we'll talk a little bit more about that. And his stool was positive for Enterovirus D68, which we're going to talk a lot about. But first we're going to go back into history again, and we're going to talk about polio myelitis. When sometimes people say we shouldn't call this acute flaccid myelitis because myelin isn't involved, but the word myelin, the word myelitis actually means inflammation or itis of the spinal cord. The word myelitis comes from marrow, and so if you think about transverse myelitis or neuromyelitis optica, they all involve the spinal cord. They're all inflammation of the spinal cord. So acute flaccid myelitis is appropriate. When it comes to polio, so polio has been around for 6,000 years based on archaeological studies. Most cases of polio are completely asymptomatic. People get infected with the virus, they get better, no issues. Some people have a mild illness and then recover, and then some people, like FDR, have a rapid onset of an acute flaccid paralysis. We have a vaccine, first available in the 1950s. We started out with an oral vaccine, but because that can cause some symptoms of polio in some people, we've moved to an injectable vaccine that does not cause polio. The World Health Assembly resolved to eradicate it in 1988, and now the Americas, the Western Pacific, and Europe are all completely polio-free. There's still polio out there, but not around here. If you look at the cerebrospinal fluid of people with polio, they have a high white count, they have a high protein, and you can usually find the poliovirus from the CSF. I said rarely. There are some theories that nowadays we could probably find it in most people who have polio, but at the time that people had a lot of polio, of course the studies were not as good to figure out whether the polio was there in the cerebrospinal fluid. And you can differentiate whether people got polio from the environment or whether they got polio from a vaccine, the oral vaccine again, because the IV version does not cause symptoms. And you see on imaging that white line going down the middle of the spinal cord and that perfect H in the middle of the gray matter of the spinal cord. Poliovirus is an enterovirus, and there are many different enteroviruses: polio, echovirus, Coxsackie virus. These are usually transmitted by an oral fecal route, and they can cause a wide variety of symptoms. Most people who have an enterovirus will have a cold. You can get a rash like hand, foot, and mouth disease. You can get a myocarditis or a conjunctivitis, pink eye. You can get a GI bug. You can get viral meningitis or encephalitis. Most of the time when an enterovirus is involved, the illness is pretty mild. And non-polio enteroviruses cause 10 to 15 million infections and tens and thousands of hospitalizations each year in the United States. So when we talk about enterovirus causing something like acute flaccid myelitis, it is a very minor thing that the enterovirus does. These viruses are everywhere. People have a lot of infections with them, and for the most part, people recover very well. In 1997, there was an outbreak in Malaysia, an epidemic, with Enterovirus 71. And Enterovirus 71 was causing this gray matter hyperintensity on MRI, and it was causing a brainstem encephalitis, meaning that people had the cranial nerve symptoms, the difficulty seeing, the drooling, the difficulty holding up their heads, and they also had a lot of trouble with thinking. They had altered mental status, which is very unlike our patient who was thinking very well. And then in 2014, there was a massive epidemic of Enterovirus D68 respiratory infections. Enterovirus D68 has probably been around for a long time, but it seemed to very rarely cause infections in people until summer 2014, when a lot of children were getting sick, particularly children with respiratory infections. And 1,153 Enterovirus D68 infections were seen throughout the United States. In Colorado, they found 12 children who came to the Children's Hospital with acute flaccid paralysis and cranial nerve dysfunction around that time. 5 of those 12 had Enterovirus D68. And they all had these distinctive anterior horn gray matter lesions on MRI, similar to polio and Enterovirus D71. Sorry, Enterovirus 71, not D. In 2014, there were a number of cases confirmed in the United States of acute flaccid paralysis, defined as rapid onset of paralysis of upper extremities or cranial nerves with MRI findings that show the gray matter lesion or CSF, pleocytosis, and high protein. And there were a number of cases in the fall of 2014, fall and winter, then again in the summer of 2016, and since then it's kind of petered off. We are not seeing as many cases anymore. So people will come in with flaccid weakness, usually proximal greater than distal, usually upper extremities over lower. Polio, interestingly, affects the lower extremities more. Think again about FDR, being in a wheelchair. And people should be hyporeflexic because it is flaccid. People get bulbar symptoms or brainstem symptoms, including the visual symptoms, facial droop, dysarthria, meaning difficulty talking, and dysphagia, difficulty swallowing. Usually, people have no sensory loss. It can be painful, though. It is rare for people to have autonomic symptoms like trouble controlling their temperature or heart rate or blood pressure, even though the brainstem is involved, and that can sometimes lead to autonomic problems. It's very rare for people to have problems with mentation or thinking, and it's very rare for people to have bowel or bladder involvement, unlike some other things that can affect the spinal cord. But there's a differential. Whenever someone comes in and they come in with new symptoms, there's other things that we think about, like, could this be transverse myelitis? Could this be acute disseminated encephalomyelitis? Could this be Guillain-Barré or acute inflammatory demyelinating polyneuropathy or acute cerebellar ataxia? All of these things are thought to be possibly post-infectious diseases, and they all present a little bit differently. Of the cases that we've seen in the United States from 2012 to 2015, the CDC has been collecting all of these cases, and there are cases in Colorado, there are cases collected in California, and there are cases collected in Utah. And we've looked at all of these cases to see how people present. The cases in California are a little bit different in that more people had lower extremity involvement, more people had altered mental status. It's thought that possibly some of the cases in the California group might be transverse myelitis and not acute flaccid myelitis. But we've been collecting all these cases, we've been trying to learn what's happening, and all in all, there were approximately 300 cases between 2012 and 2016. Not a ton of cases, but these cases often looked very serious, as we're going to see later. Generally, when people come in, we get an MRI of the head and the spine. That is looking for that characteristic gray matter lesion on the spine. If you see something else like problems with the white matter, if you don't see that perfect H, but instead you see that everything is hyperintense, then you'd be more concerned about something else like transverse myelitis. And usually in the cerebral spinal fluid, you're going to see that high white blood cell count and elevated protein. Sometimes we try nerve conduction studies, but early in disease you might not see anything. And I'm going to talk a little bit more about nerve conduction studies later. An enterovirus is best found in the stool. Sometimes we use a nasal swab because it's a respiratory pathogen. The problem with enterovirus is just because it's there doesn't mean it's the cause of the problem. Because just like we talked about, it causes a lot of different things. And you could certainly have a respiratory infection with enterovirus and then also have something else going on. When they look at the cerebral spinal fluid of these patients, and they have at the CDC, they don't see any infectious agents of any kind in the cerebral spinal fluid. And they look with a global PCR where they're looking for anything that we know, anything that we don't entirely know. They look for antibodies against different bacteria. They look for antibodies against the body's own proteins, and they haven't really found anything, with the exception of one patient who did have enterovirus D68 in the cerebral spinal fluid, but also had a bloody lumbar puncture, so it might have been in the blood. Which means that we don't know. Is this infectious? Is it caused by enterovirus D68? Is it that people get something, maybe enterovirus D68, and then after the fact, their body responds to it? And that brings us to Koch's postulates. So Robert Koch was a German physician in the late 1800s, and he was trying to figure out how we could say that cholera was caused by the cholera bacteria and how we could say that tuberculosis was caused by the tuberculosis bacteria. Nowadays, we actually use the Bradford-Hill criteria, but the Koch's postulates are so nice and simple that I thought that would be easier for use in this talk today. The most problematic part of Koch's postulates is that he says you have to find the microbe in all cases of the disease, and healthy people can't have that microbe. But even in cholera, which was the first thing that he was studying, people can have cholera and not have disease. And he wasn't thinking about viruses, which can definitely be in healthy people and not cause disease. But he said you have to be able to take it from the diseased host and use it to infect something else. And then you should be able to get that microbe back out of the new host that you've now created. And so that's what they did in Colorado. They took some mice and they injected them with enterovirus D68. And they managed to, the animals actually became paralyzed. You can see here the weakness in the lower extremities. They then took the spinal cord out of that mouse that has the paralyzed legs, and they ground that up essentially, and they injected it into another mouse, and that mouse also became paralyzed. So we know that enterovirus D68 can cause a flaccid paralysis if you're doing this with mice. And they showed that the anterior horn cells down here were the part that was involved. So with that, and with these cases that happened in the winter of 2014 and the summer of 2016, summer and fall, when we had more enterovirus D68 respiratory cases, we think that this correlates to enterovirus D68 being the cause of acute flaccid paralysis, but it's not 100%. And one group looked through the Bradford-Hill criteria, which are more complicated, and said, okay, when we look at the evidence here, it doesn't fully meet the Bradford-Hill criteria. You can't really say 100% enterovirus D68 is causing acute flaccid paralysis, but it supports a causal relationship. It's probably the cause. But enough about that. So what do we do once we say that enterovirus D68 is the cause, or once we say that this patient has enterovirus D68 and has acute flaccid paralysis? Many different treatments have been tried, and because we think this is infectious or post-infectious, we focused on treatments that help in other infectious or post-infectious diseases. For instance, intravenous immunoglobulin, which involves taking the antibodies from other people and putting it into someone. It can be something that's used for a variety of different diseases. plasmapheresis, which means taking the antibodies out of the person's own body, and steroids, which can be immunosuppressant, antivirals, which can be helpful. But with all of these different treatments, no response has been seen. We are pretty sure that steroids don't work. We are pretty sure that IVIG probably doesn't work, but most patients will get IVIG anyway. Steroids we don't want to give if they aren't helping because they could actually be harmful if it is actually an infectious cause. IVIG doesn't seem to hurt, so most patients will get it. And plasmapheresis doesn't seem to help. Time course could be important. Of these treatments, IVIG is the least likely to cause terrible side effects and possibly to have to be helpful on some level. But what would be really nice is if we could target the virus that we think might be causing the problem. So one group was researching Enterovirus D68 before all of this because it is a virus that affects cattle. And they took a lot of different cells and infected them all with Enterovirus D68, and they used 1,500 different agents. They used different medicines, they gave it on the cells, and the one with fluoxetine or Prozac killed off the enterovirus in the cells. So fluoxetine or Prozac seems to be something that can kill off this virus. So now we give patients fluoxetine. We give them 0.75 milligrams per kilogram, which is a high dose compared to what you'd give someone if you are trying to treat their depression, once a day for 7 days. It doesn't usually cause much in the way of side effects because it's just such a short-term course. They have not yet published, Colorado is doing a study on this right now. They have not yet published the data. Word of mouth is that it does not seem to be helping very much, unfortunately. And that may be because even if Enterovirus D68 is involved, it may be that it is a post-infectious process, that killing off the virus doesn't actually help with the disease itself. So then the question is what happens long term? And there was a study out of Canada where they looked at 25 different patients who had presented with acute flaccid myelitis. Of those, 5 actually had Enterovirus D68 positive in their, and from a nasal swab. And they looked at the expanded disability status scale. This is something we use often in multiple sclerosis and in other diseases that can cause disability to rank patients and see how they are doing. It goes from 0, which is totally normal neurological function, up to 3, where you have moderate disability, through 5, where your disability is affecting all the activities of your daily life. 8 is where you're restricted to a bed or wheelchair. 9, you're bedridden, and 10 is death. And they looked at these patients, the 25 patients. They were ranging in age from less than a year of age to 15. And what's interesting is that over the 18 months they looked at this study, they had some people lost to follow-up, but of the people who followed up for the full 18 months, some were still recovering at 18 months. And that's really striking because in other diseases like that we've talked about tonight, like Guillain-Barré or transverse myelitis, if you haven't had a significant recovery by about 6 months, it's pretty unlikely that you're going to get a whole lot better. But with this one, it seems that people continue to get better over time. And the hope is that even these patients, and some of them were extremely sick, 9.5, 8.5, when they came in, ending up at a 6 is not ideal. Hopefully they will keep getting better over time. So, quick summary at this point. Acute flaccid myelitis, you usually get flaccid upper extremity weakness with a bulbar weakness. It can be painful. It's associated with Enterovirus D68, but we don't know entirely if that's the cause. We don't have a treatment that we've shown to be helpful. And patients get very sick. They are often very sick when they leave the hospital and don't necessarily, but we think they will continue to get better over time. And currently Colorado is studying fluoxetine, and these epidemics that have happened are dwindling off. And we don't know if there's going to be another big bump in that curve over there, or if it's going to stay flat and won't come back. But the thing about epidemics, as we talked about, is that they come and go. And viruses and bacteria change and cause different symptoms. If you think about strep, strep throat used to be a precursor to rheumatic fever and heart disease. We treat children with antibiotics because we're trying to prevent that, but it seems like even when we don't treat children with antibiotics, that's a very rare outcome of strep these days. Whereas in Samoa, that's not a rare outcome of strep, and they probably have a different strain of strep there that's causing those symptoms. Bacteria and viruses change all the time. And the developing immune system is different, and diseases can look different in children. It's really striking that this is something that we virtually have not seen at all in patients over 18. If you think about varicella, chickenpox, children get chickenpox and they get a rash and they have a fever, and some children have complications. Most children survive and do great. If adults get chickenpox, and have never seen it before, then they get pneumonia with a mortality of 10 to 30%. The immune systems of children and adults are very different, and we don't entirely understand how they're different. And it's not a case in which the child immune system is better. Some illnesses affect children much more, some illnesses affect adults much more, but they are very different and have to be treated differently. And in May and June of 2018, that's this year, there were 13 children in Colorado again who came in with altered mental status, ataxia, myoclonus. Some of them, 3 of them had a rash that looked like hand, foot, and mouth disease. 1 had seizures. They all had brain lesions on MRI, and this was associated with Enterovirus 71. So it was in the papers in Colorado, multiple cases of Enterovirus A71 confirmed. Here's how to protect your kid. The article said, don't drink pool water and wash your hands, which I think is good advice for everybody. But I think that this is really striking. I don't know if Colorado is just a hot spot for Enterovirus, or if it's that they are more observant and possibly catching on to these epidemics before other people are. I'm going to go through some cases so we can use what we learned to diagnose some patients. Some of these have were diagnosed with acute flaccid myelitis, and some of them not. A 10-year-old girl with autism came in with upper extremity and neck weakness, kind of like our other patient. She had had rhinorrhea and cough a few days before, and her parents said she just wasn't acting like herself. She wasn't using her left arm. She was really unsteady when she was walking. She couldn't hold her head up, and she was coughing when she drank liquids. When she came in on exam, she could squeeze with both hands, very strong, but she couldn't lift her right arm at the shoulder or left arm at the elbow. She seemed very weak with walking, but she was not ataxic. It didn't seem to be a cerebellar problem. It seemed like sensation was intact. This was a little girl who was nonverbal, and so this exam was more challenging. We thought that the left arm seemed painful. She didn't want to move it. And her reflexes were intact in the right bicep and right brachioradialis, and absent in the left bicep, and 1+ in the left brachioradialis. Her reflexes in her legs were normal. And when we tapped her, she had 10 red blood cells, 79 white blood cells, so normal is 0 to 5, and protein of 16 milligrams per deciliter. And when we looked at her imaging, there's that white line going through the spinal cord that you can see a gray matter lesion through her entire spinal cord. One of the interesting things about these cases is that it often appears that the entire spinal cord is affected, even when the only symptoms you see are upper extremity weakness. You don't see that the legs are involved, but the line goes all the way down to where the legs should be involved. And there's the axial view where you see that H in the middle. This little girl got IVIG over 5 days. She did get fluoxetine. She never was positive for Enterovirus D68, and she went to rehab with a residual left upper extremity weakness and with a diagnosis of acute flaccid myelitis. And she didn't come back in for follow-up, so hopefully she is continuing to do well. This is a 6-year-old girl who came in with fever, headache, nausea, and vomiting, and had a left gaze palsy, so she couldn't look to the left. And of course, because of these fevers and headache, our initial concern was for meningitis or meningoencephalitis. And when we tapped her, she had 650 red blood cells and 45 white blood cells, so high, and a protein of 76 milligrams per deciliter. So at this point, our biggest concern was meningitis, and she was started on antibiotics. But while she was admitted, she suddenly developed upper extremity weakness, proximal more than distal. She lost her reflexes in both her upper and lower extremities, and we determined that the reason she couldn't look to the left was because she had a left cranial nerve 4 palsy. Her TAP was repeated. She had 6,000 red blood cells, 105 white blood cells, so still high, and a protein of 76 milligrams per deciliter. And on imaging, she had hyperintensity both in the brainstem and cerebellum, and then all the way down her spinal cord again. So she was also diagnosed with acute flaccid myelitis. She was treated with steroids. I believe this was early, before we knew whether or not steroids were going to be helpful. She was treated with IVIG, she was treated with fluoxetine, and her stool PCR was positive for Enterovirus D68. As of last December, she was still weak in her right upper extremity and still complaining of some double vision. But as of April, again, possibly showing a longer course of getting better, she was walking, running, and about 90% of her baseline. The next one is a 2-year-old who is healthy and developmentally normal, unvaccinated, who came in with acute lower extremity weakness. He woke up in the morning, he's 2, so he refused to stand up all day. He seemed to be otherwise normal, thinking normally. He didn't have any problems with peeing or pooping. He didn't drool, he didn't have facial drip, no other symptoms but refusing to stand and walk. And when he came in, he had no reflexes in his lower extremities. So with him, the main thought was possibly Guillain-Barré. We tapped him, and he had no red blood cells, 1 white blood cell, a protein of 36, which is normal, and a normal glucose. So his cerebrospinal fluid looks 100% totally normal. Again, which would go along with the diagnosis of Guillain-Barré. When we took a picture of him, his spinal cord looks totally fine, which again goes along with the diagnosis of Guillain-Barré. So why are we talking about him? Because overnight, his weakness spread, and it became very profound in his proximal arms, in his trunk, and in his bulbar muscles, so the muscles controlling his face and his neck and his eyes. So he had profound neck weakness and ptosis, meaning his eyelids were drooping, and he had a hard time talking, he had a hard time swallowing. He developed urinary retention, he appeared very painful, and he had no reflexes anywhere. So our question was, could we have done this TAP and this MRI too early? Could he have then developed acute flaccid myelitis after that TAP? But his mother refused to repeat those things because we told her, honestly, that it wouldn't really change how we treated him. And she didn't want to do it just for fun. We did do nerve conduction studies on this little boy, and his motor responses were reduced or absent, and his sensory responses were totally normal, which is not something you'd expect with Guillain-Barré. Guillain-Barré generally affects both the motor and the sensory nerves. There is, however, a variant of Guillain-Barré, which is very, very rare, called acute motor axonal neuropathy, or AMAN, but it's very rare. So at this point, we are not sure if it was acute flaccid myelitis or Guillain-Barré. And this is his actual nerve conduction studies. We looked at the CDC and the Colorado study criteria, and they said you need to have acute onset of a flaccid paralysis, and you need to have either an MRI that shows a lesion in the gray matter or cerebrospinal fluid that has a pleocytosis and protein. So we said, if you can have either or, wouldn't it be possible that you could have neither? If you can have an MRI that's positive and not have CSF that's positive, or if you can have CSF that's positive and not have an MRI, wouldn't there be a possibility that maybe you'd have neither? And the folks in Colorado said they didn't think that you could catch it too early. And the folks at the CDC said that, that they did think that possibly if we repeated it, it might have been too early. It's hard to say. So the things that go along with Guillain-Barré were that the lower extremities were affected first, negative LP, MRI and LP. And the thing that's most convincing to me is that he had a relatively rapid recovery. By the time he left the hospital, most of his bulbar symptoms had gone away. So that was really reassuring. And then the argument for acute flaccid myelitis was this very rapid progression that we don't usually see with Guillain-Barré, and that he had no sensory loss at all. And he had a very large panel looking for infections, and he had none, including Enterovirus. We did treat him with IVIG and fluoxetine, and we sent an antibody anti-GQ1B, which is associated with Guillain-Barré that affects specifically the brainstem, and that was also negative. 2 months after he left, he had normal speech, He was rolling over and he was sitting up independently sometimes and starting to use both hands. And again, that's a very rapid recovery for something like acute transverse myelitis, acute flaccid myelitis, even though it seems like he's not quite back to normal yet. The last case is a 6-year-old who came in with, again, lower extremity weakness. She was walking with her mother and she seemed tipsy and kept falling over, difficulty walking, and then her arms became weak and her mother brought her in. So she also had a TAP and her cerebrospinal fluid had 1 red blood cell, 38 white blood cells, so high, but a normal protein. And again, if you recall our other cases of acute flaccid myelitis, the ones that we saw had high white blood cells and high protein. And when we did her MRI, there's the white line down the center of the spine all the way down, and you can really see that gray matter hyperintensity in the middle. But what looks different about hers is that it looks very, it looks almost swollen. It's not just a perfect stripe. It looks kind of like a blurry, puffy stripe. And if you look at the axial views, you don't get that perfect H really, you get kind of a blurry, puffy H. So her lower extremities were affected first, which doesn't usually happen with acute flaccid myelitis, and she had no brainstem symptoms, but she had this gray matter involvement on her MRI. So we wondered, is this transverse myelitis or is this acute flaccid myelitis? And the one thing that can distinguish between the two is your neurological exam. So we looked at her reflexes, and she was hyperreflexic, 3+ in all extremities. So this was not acute flaccid myelitis, which would be hyporeflexic. This was transverse myelitis. And then she was treated with steroids appropriately. She was discharged to rehab and developed visual symptoms later and was diagnosed with neuromyelitis optica. So that's just another interesting case. So acute flaccid myelitis we talked about, usually going to be upper extremities and brainstem symptoms and can be painful, associated with Enterovirus D68. We don't know how to treat it, and we're studying fluoxetine. And the differential includes other things like Guillain-Barré, transverse myelitis, acute disseminated encephalomyelitis, and acute cerebellar ataxia, which we didn't discuss too much tonight. But the MRI and the reflexes can help differentiate between those post-inflammatory or post-infectious or inflammatory processes and acute flaccid myelitis. And I'd like to point out that I did a podcast for the Journal of Child Neurology on acute flaccid myelitis, which you can find at the Journal of Child Neurology homepage. I interviewed Anne Ye of Sick Kids in Toronto about that longitudinal study where she was looking at children over a long period of time, and Jim Savar, who's the big, the primary doctor working with acute flaccid myelitis at the CDC. Thank you.